please. No, I'm just teasing. That's it. That's it. Yeah. Thank you very much. So liver failure was a presentation you guys asked to have maybe put out there. We've had a lot of liver failure patients recently. I don't know why the uptick. Usually we don't get this many. We've had a year's supply, probably in a month, and that was just last month. This month we've already got more. Sometimes there's two kinds of liver failure. Name two kinds. Yeah, and the other? So acute and acute on chronic. If they're going to be in your ICU, this is mainly from an ICU point of view. If they're going to be in your ICU, they're either acute liver failure or acute on chronic liver failure. Can you name two causes? I have props.
On the screen.
And name the other one. Non-alcoholic. Name a cause of non-alcoholic liver failure. What? Name the most common cause of non-alcoholic liver failure. If that was to be a question on an exam. There's no exam. Tylenol. Tylenol is the most common cause of non-alcoholic liver failure. And yeah. Now, if you show up and take a handful or the bottle of Tylenol and use your vodka to chase it, and vodka seems to be I brought vodka only because it's actually water. Only because I carry it with me everywhere. No. It's when you get to ask most of your alcoholics or most of these guys' presentations, it's almost like they're either a 30-pack a day drinker or it's vodka because they can just slam that stuff. And I like to interview them a lot over the years, a few decades. And a lot of times it's vodka, almost always is. Dr. Evans would always ask in the morning, so what kind of liquor? He always was curious what it was. And it's almost always vodka is the heavy drink. They put it in anything, carry it anywhere. But anyway, so I put together a PowerPoint real quick and I try to keep it fun. But the real stuff, what I wanted you to kind of get out of this is I'm you guys. I have my resources and I go to stuff. This book, the little ICU book, is the smaller version of the ICU book. I recommend getting your hands on these. It's not mine. SLU made me use this for acute care. Anyway, in here is liver failure, and I went right to it, and it narrowed it down to 1, 2, 2 pages in a nutshell of what you're really looking for. Acute liver failure, acute on chronic liver failure. After that, worrying about spontaneous bacterial peritonitis. I'm not going to get into hepatic renal failure, that little game. And then the clinical features, diagnostic approach, like what kind of things you're going to look for. What's the provider going to look for? And then treatment of, which is you're going to treat. Dr. Bosdick used to say if you're going to treat spontaneous bacterial peritonitis, the best thing to do is to actually get the culture first, like most things, and then start the antibiotic. But that's actually not always realistic, but it's ideal. And then you throw an antibiotic on. So a lot of times if they're sick, you got to throw the antibiotic on. I'm giving you a summary up on the front side of this. So albumin, sodium restriction, spironolactone, Lasix, large volume paracentesis. If you take more than 5 liters, you're going to it says in this book, in this reference, you would need to get albumin replacement. And that's kind of, in a nutshell, simplifies it. The tricky part is they can get ugly in a hurry from the bedside point of view. That's why these are exciting. They're either super sleepy or not breathing, so lethargic, their GCS is a 3 and you're going to have to intubate them, or they're vomiting blood and it's a nightmare of an airway, or they're bad shit crazy, rolling around in bed, just flopping like a fish. Or they're passing GI blood too from the other end. So they're either bleeding out both ends, or they're bleeding out both ends and unresponsive, or they're just crazy. And they're hard to treat. Lactulose is a good drug, but they got to be awake enough to take it. And if they're not awake enough to take it, you need to put an OG or an NG tube down. And if you do that, you might make them bleed or knock something off because they might have varices. So it's just every time you try to do something with these patients, it seems to be contraindicated all the time. They don't have good IVs. If they do, you know where the most common best IV spot is on a liver failure patient?
Belly.
Yeah, true.
We've got them there before.
If you have to.
Your bellies.
The external jugular, the EJ, is the juiciest son of a gun because of the portal hypertension. All the jugular, the congestion, all this hepatic congestion, uphill. It's going towards the esophagus for the varices, but all that if you put an ultrasound on there to put a central line in for the IJ next to the EJ, that sucker is usually on the ultrasound is like it's huge. It's barely compressible. And when I get in there, the first few times I've done a central line on a bad liver failure patient, you think you hit carotid because it's just gushing. There's so much back pressure. It's coming out of there. It's impressive. I thought, oh crap, what did I do? But the EJ is it's juicy. It's probably one of the juiciest EJs you're going to see. So anyway, I always found that very interesting. So in a crash and burn, that might be the spot to go. EJ. Try to stay away from the IJ if you can. For the last 3 years, I've been using this page. This was from Society of Critical Care Medicine. This has been their recommendations for guidelines for management of adult acute and acute on chronic liver failure in the ICU. And we suggested or recommended the strength of recommendation and the quality of the evidence. And this came out in 2020. I kind of self-taught myself liver failure management because I had to. So that's what I did. And I found I got to have some guidelines. And then GI stopped coming. Really need to teach myself because no one's coming. You have GI present now and their contract and they're coming now. If we end up losing a contract or lose somebody, we're going to be back to just Dr. Moore and he can't be in 900 places at once. So with no GI presentation or representation in the ICU, I was going to have to do my own thing. And these guys are coming in the middle of the night. They're not coming in 2 in the afternoon. I'm getting my liver failure, decompensated liver failure at midnight. So I found this. This was 2020. You guys asked for a presentation. This magazine came in the mail. It comes every month. May 2023. That's this year. Executive summary, guidelines for management of adult acute and acute on chronic liver failure in the ICU. Yay.
They said Wayland, which region?
Ta-da! New recommendations, mostly the same. So I got you that, I think. Yeah? Okay. And then in there is 2 articles. One was a short version of only like 3 pages, which is nice. Read at your convenience. Then did an executive summary with narrowed it down to maybe 6 or 7 really good ideas. And then on this big fat one is 13-page article. It's called Part 2. They have 28 recommendations for the acute liver and acute on chronic liver failure. And with that and I brought the actual magazine, but these are the ones that I'm going to be following. Okay. All right. And then I had done something with, is it Ochang? Dr. O, right?
Yeah.
Awesome dude. He's a go-getter. I think the main thing, if you want to not make him mad right now, is if your patient comes in with a GI bleed, he wants your patient to be MPO. That's it. If you're consulting O, make him MPO. That's what he actually put on his name. If you Google his name in Volt, if you go into Volt and pull him up and you want to message him, it now just comes up at the top. And I remember the day he told me that sitting in the holding area in PACU because he was pretty frustrated. He's like, so MPO, if you think your patient's going to get a scope, if I think they're going to get a scope, they're MPO. Reglan, he ordered Reglan last 2 weeks ago, and I was like, why? This is ridiculous. Increases motility of the gut. He wanted to get whatever this patient had eaten moving on down the line because he's going down. I was like, smart. Okay, cool. I'll reorder that. My bad, dog. So anyway, I thought that's something new, right? I'd never seen that ordered. So, and he's more aggressive. He's more active. He doesn't always sit and wait. I think Saturday he's tired. Sometimes he sits and waits, but mostly through the week, I think 5 out of 7 days he's going to show up in the middle of the night and scope your patient. And he is at the bedside with his team. They're all tired and they're getting it done. And I've had him. We've been in rooms on speaker with IR while everyone's still running a camera down the gut, and that's just been 2 weeks ago. So people that are going to be involved is OR, maybe worst case scenario, which we got to IR, and if GI can't get to it, and then GI first.
What's IR?
Interventional radiology.
Oh.
And their move is if you're bleeding from somewhere, like in the gut, they're going to look for the vessel that's supplying that spot and then embolize it.
Okay. Thank you.
I have the vodka, Taylor, if you need it, and Tylenol. So anyway, back to Dr. O. I went ahead and snagged his GI attendings, like his sample, and saved it for myself. This was an example of when you do an H&P or a consult note, when you get to the impression and plan, like what's the diagnosis and what's his management of. This is just one example of one patient without the patient's name, of course. And so we started out with acute hepatic encephalopathy, meaning the ammonia level was elevated to a point. There's not a special number. Dr. Bosdek used to tell me you don't have to chase that ammonia number. It's the burden of the ammonia on the patient. So what might be a burden on the patient for encephalopathy for one might not be the same for the other. So if it's 800, 600, 200, it doesn't. What you're looking for is the clearance of the ammonia and the patient mentation improving. So it's not, you can check a number, but there's not a specific goal. There's not that's bad, and there's not that's great. And lactulose is the drug of choice to clear the ammonia level. And what I have experienced I remember being a new grad at Kansas City and coming on and working I was getting overtime when I was still in orientation. So I was working 5 nights in a row. And what I realized is nobody had been given the lactulose. The day shift nurses, the nursing before me. And I was like, well, maybe I should give this drug. And my preceptor taught me, and I gave it to him, and no improvement. Right. And I'm giving it around the clock, and they're shitting up a storm. And then the next day I give it around the clock, and the next night around the clock. By day 4, the person starts to wake up. By day 5, I'm getting them up to the bedside commode and talking. I think it's probably the good thing, because nobody wants to give this. This is a lot of stinking work. This drug is going to be your worst enemy, but it's the best thing. You give it, and then once it kicks in, and they're just going to be pooping up a storm, and you're going to do nothing but clean up stool all night. It's exhausting. But I got to see this person completely comatose, and by day 5 awake and talking. And I was like, holy crap, this stuff works. So give it. Don't check it off, not give it. It's the most common drug on the MAR that we all cheat and lie and don't sign off and don't give and ignore and sign off to the next shift and all the fancy tricks. I speak from experience. Give it. And normally when I see it ordered, we're ordering it wrong. The doc says, GI will tell you to give it 20 Q8, 20 Q6. He'll put his recommendation but not order it. We order it 10 PRN. I think it even comes up that way when you go to click on lactulose and order it. And that's not right. And it's not correct. No one's going to give it because it's PRN. It needs to be scheduled. 20 is usually a good starting dose. It can go up much higher too. If you read different resources, it'll tell you you can start the higher dose and give it until the first bowel movement. So it's going to be repeated. This is given if they can swallow it, great. If they're not awake enough, you're going to have to find out if they have varices, and you're going to put an NG or an OG in, or are you going to make them bleed? What are their coags? Are they, because you start a nosebleed, you might not get that sucker stopped. And then, or if you put an OG or NG tube down, you might knock a band off a varice, and then you're in trouble too. So there may be a absolute no. You can't even do that. So it's going to be lactulose enema. And on there, you'll see the dosage for that. head CT is another thing that guy had on, GI doc had on here. You need to try to rule out any other causes, especially if their coags are bad. You know, do they have a spontaneous head bleed too? Need to rule out that for the encephalopathy. But the main kicker is the ammonia level and lactulose. On here, there's a MELD score. If you have MD Calc, you can actually pull up MD Calc, go to MELD. The MELD score, MELD-NA, is the new scoring system. There's others. There's always different ones, but that's the one he was using, so I thought that was useful. And then there's a mortality risk. Then you can start to find out that your patient probably has a 50-50 chance of survival. It gets worse, depending on if they got spontaneous bacterial peritonitis with it too. So he scored the patient at risk for infection in the gut, because you may know why you get SBP, why that's a risk in these liver patients with decompensated with ascites fluid in the peritoneal area. If you think about peritoneal dialysis and the osmotic pull, so, it's translocation of bacteria across the bowel wall into the peritoneal fluid where it shouldn't be. And then you get peritonitis, fever, abdominal pain, and abdominal distension. He ordered all these cool labs. I usually look for you have to look for other causes of hepatitis, A, B, C, D, ANA, AMA, all these other fun things. And then in the hospitals rounds years ago, Udi had told me that if you have enough cirrhosis or inflammation of an organ like the liver, eventually it can turn chronic inflammation of something can turn into a cancerous too. So, I obviously right away he threw in here liver ultrasound to check out for portal vein thrombus. We've had a few of these guys with clots in the portal vein. I didn't think they were even non-alcoholic patients, which was kind of interesting. Some of these get treated with heparin, some of them don't. That's what I've seen in the last month. Some don't get any treatment of it. It's a chronic thrombus. It's strange. Avoid alcohol and then a low sodium diet. Acute alcoholic hepatitis. Apparently there's a scoring system for that you can check out too if you like. This one held off on steroids. Esophageal varices, cirrhosis with banding. The treatment on that for some of this is more of a long-term treatment. Nadolol is a beta blocker. Octreotide drip, and then repeat endoscopy in 1 month following. You got to survive the ICU stay for those last two treatments. Our biggest issue usually is coagulopathy and airway. Coagulopathy likely due to patient's alcoholic liver dysfunction. Vitamin K5 PO daily for 3 days. So the pharmacy threw me some gang signs when I ordered vitamin K last week. So I'll look into it and see why, but I don't know what their deal is. And they called twice on both patients, and it's like I'm not talking to them. To come out of a patient's room away from the bedside to explain to them why, and they went to college for it. So if he'd ordered it, they wouldn't have got a phone call. So it's funny. Acute kidney injury to rule out hepatorenal syndrome. That's a whole nother subject. Continue octreotide drip. So we usually see Protonix drip, octreotide drip, mostly. Octreotide has a place in some of them and some of them not. Thrombocytopenia. So we have low platelets in these guys and high INR. If you ever had a question on an exam, usually it's INR is elevated as your first hint. You got to question why your patient's INR is elevated. And if your patient's not on a blood thinner, you need to look at the liver right away. And do we have a liver problem? And sometimes they lie to you. I don't drink. No. Okay. Hemorrhagic anemia. And this is a real patient, of course. That, 2 months ago? Esophageal varices got banded. So treat the source. Try to find the source of the bleed. Is it internal? Is it external? Can you see it? Is it coming out up? Is it coming out low? Is it lung? Is it esophagus? Because they run side by side. It's going to be risky. Low sodium diet once again. And then the bilirubinemia is you can have bad liver enzymes and normal bilirubin. That's usually a shock liver because you have a functioning liver. And then you have high bilirubin and normal, almost normal liver enzymes. You have a liver that's just chronically screwed up. It's not even, doesn't even show you it's angry anymore with elevated enzymes. And don't forget thiamine and folic acid, because they're on there for alcoholism. And they're usually a lot of electrolyte issues, usually low. If you remember all the things the liver does, she's gone now. Anybody want the vodka? No, just teasing. I'm looking for my mouse, I promise. How does she get to this screen? Anybody know how I move on? Oh, I found it. Okay, so let's start with my PowerPoint. I tried to make this fun. Just laugh. Huh? It's still there. Just laugh at my jokes. I try to make the titles entertaining because liver failure is not that cool. Liver failure is kind of not cool. So you have acute liver failure, chronic liver failure, acute on chronic, decompensated, and then I talked about the MD calc and then the mortality risk. I always thought those are interesting, the scoring, because you can really, like, I feel like my patient's sick. Well, then you can quantify it. My patient has a 52% chance of dying today. Then it gets lower. If I remember right, DIC was like a 5% chance of survival. That was what they used to be the information with septic shock. You go into DIC. ARDS is the same way. If you start thinking about that, when you're getting report on your ARDS and DIC patient or your liver failure patient and DIC, it's like you kind of can't lose. You're like, oh, well, they got a 5% chance of survival, so I'll see what I can do tonight. Takes the pressure off. Next, acute liver failure, and I made up Cliff. I thought it was fun. So I have Alf and Cliff. This is not a real word. I made that up. Acute on chronic liver failure. So Alf is abrupt, rapid screwing up of the liver function without prior liver disease. So that's the acute. They don't have prior liver disease. I don't know anything what you're talking about. This has never happened to me before. No, I don't drink. No, I didn't use any Tylenol. We don't even keep it in the house. So it's uncommon. 1 to 6 cases per million. Most cases are viral hepatitis. You said that. Or drug-induced liver injury. Most presentation symptom is the encephalopathy. So they might come in altered mental status, get a CT of the head. They'll do a urine drug screen in the ED. Things don't make sense. They'll check alcohol, Tylenol, aspirin. They might even give them Narcan in the field. So they checked the sugar. It was normal, or it was 88. It's on the low side. They don't know why. It's not diabetic. So there's going to be some incomplete information in the ED, and then your lab work might be you're going to see some liver enzymes that are off and stuff. But the main presentation was altered mental status, and it's not adding up. Leading cause is in the United States is Tylenol overdose. Well, I brought in the Tylenol. I was like, "What are you doing? Are you taking the aspirin to work?" I'm like, "No, it's Tylenol." Are you really taking vodka? I'm like, "Yeah." Cliff is not a real term. I made it up, and the names have been changed to protect the innocent. Great. So this is Cliff. Say hi, Cliff. Acute on chronic liver failure. Most liver failure is with patients with chronic liver disease. So this is acute on chronic, who get abrupt deterioration of liver function. So I got a shitty liver, but I'm living with it. Life's good. I'm doing okay. How you doing today, Cliff? I'm fine. Okay, I'm not. Something happened. What happened to me? Why am I not so sick? Why am I sicker? Now I'm going to ER. Usually for infection or variceal hemorrhage. Those are the decompensated part. So acute on chronic liver failure symptoms are SIRS, systemic inflammatory response. They look septic, but no source of infection. Fever, leukocytosis, white counts up. I always have a little bit of a distended abdomen. I'm not normally this fat. I feel bloated. I don't know. I've been noticing it. I thought something was different. My pants are tighter. Worsening ascites. So they had ascites that they live with, but it's getting worse. Or maybe they get tapped once a month, and this time, now it's like, I feel like I need tapped again. This is how I feel before I go in to get tapped, for example. Lethargy, increase. I'm sleeping all the time. I got no energy, or to the point where maybe family's like, I had to wake him up. He's not waking up. I called the ER. Renal function starts to suck. or already sucks, and you live with some chronic liver, chronic renal, but they're all borderline, and now they suck more. So acute on chronic mortality is considerable in this group, ranges from 35 to 70%. It's a lot. Why you yellow, brah? See, these are supposed to be fun. Non-alcoholic fatty liver, non-alcoholic steatosis, hepatitis. Yes, help me out. Yeah. Alcoholic liver cirrhosis and failure. Not all liver failure is alcohol. Sometimes livers are stupid. Why are you bleeding to death and stuff? It's weird. No, I'm dumbing it down because when it is happening, we're all like, it's like, somebody's like, I'll just get some towels. No, it's everywhere. It's on you. It's on me. It's on my shirt. It's in his airway. So right away, INR. If you think INR, I go ahead and throw fibrinogen on it. It's a blue top. If anything, get a blue top. And everything that comes with it. Yeah, get a blue top. INR, PT, PTT, fibrinogen. But the main two kickers that's going to be useful for this is INR and fibrinogen. And then we need to start treating it. Oh, type and cross while you're there if you have some time. Otherwise, in the last few, we're doing level 1. We're getting transfuser, and I've gotten the cooler up there, and we're doing mass transfusion and going to OR. And oh, my God. And they're not even stable enough to go IIR. And I won't come to us. And Cath Lab loves it when we code a bloody mess in their Cath Lab. And you can't stay in Cath Lab all day. Like, that's for STEMIs and stuff. So a lot of this ends up being scoped at the bedside and banded. They can bleed a ton. I once, more than decade and a half ago, probably over 15 years ago, had a doc come in one morning. And I don't know why. It doesn't make sense. And he came to see a patient, and there was a band that was on, esophageal variceal band. And the guy was just coming by to do a consult because to evaluate a patient of his, and elected to call in the team to remove a band. I was ICU charged, and I don't remember why he felt it was necessary to remove the band. And there's probably something I don't know to this story, but it was very interesting because that patient died in a matter of seconds by a band removal, and that's all they did. They had a camera and the GI team, and he was in here, and I was down the hall, and it's like 6 a.m. and I'm getting updates. If you've been in a charge nurse, you've done that. I'm working down the hall getting updates, and I look at my monitor, and it's tachycardic, and then it's bradycardic, and now it's starting to look like, is that room 15? So I head right down there. I was like, are we doing okay? And he's like, I said, do you have a pulse? Everybody's gowned up. It's the three-man GI team, and they're scoped, and they're in the gut. And I can see on the camera he's trying to stop a bleed, all from a variceal removal. The guy was awake and alert 1 second and dead the next. And like I said, there's parts of the story that I don't know, but what I got out of this is how important and how quickly your patient can bleed to death in just one band that was removed. And I said, if he doesn't have a pulse, which that looks like in my experience, no pulse, we should start CPR. But if you're just bled to death, CPR won't fix this. I should probably wait and let you keep trying to stop the bleed. And the fact that I said it out loud, all he could do at the time was try to stop the bleed and nod. And because that's right. If he doesn't stop the bleed, CPR's, it's useless. So that's a different lecture that I did last time we did this. Was I tacked on there was trauma and CPR during trauma. If you have like pneumothorax or cardiac tamponade or bleeding, exsanguinating out, there's really not a place for doing compressions until you've refilled the tank. So, which is like a new idea in your priority of things, where to put compressions with no pulse. Different subject. If you ever want that, I'll send you the info. INR, fibrinogen, D-dimer, DIC, hemoglobin, platelets, type and cross. This is in a nutshell all the things you're going to like. I've sent a blue top, H&H. H&H and automated platelets turnaround time should be about 5 minutes. CBC could take you an hour. It can clot, hemolyze, we lost that. H&H and platelets, for some reason, they never lose their H&H and platelet. ABG Complete gets me an H&H and a lot of good information, but no platelets, right? The liver failure last week was like a platelets of 35. So came in that way. Hemoglobin 4 something. We've had a few of those last week, just last week. Hemoglobin's a 4, platelets in the 30s. INR is 4. I don't know, things like that. Fibrinogen was under, somebody had fibrinogen under 100. There's not really like a sweet spot, but I'll tell you what, if it's less than 150, I kind of, and they had some bleeding risks. So cryoprecipitate is your friend for that. That's what helps fibrinogen, brings it up. If you can't form clots, that's not good. So you got to stop, got to fix that. You can, if you've been in mass transfusions, you can do uncrossed mass blood. You got to sign some papers. You get the mass transfusion, and we just get started, and we save the patient. Just need to know that there is a bypass to all that stuff, and you just get a mass transfusion. We initiate it and get it up here. Yeah. Taylor said something important.
You have to repeat it.
Yeah, I know. I think the idea is if you overzealously resuscitate too fast, too much volume under too much pressure, you increase portal hypertension, which increases the force of the bleeding out of the variceal. Same goes with trauma. If you have an arterial rupture in the abdomen or somewhere in traumatic event, if you over resuscitate or too hypertensive, you're increasing pressure inside the vessel walls of the patient systemically, and if you increase that, you increase bleeding. You also have, so there's arguments on there for you can allow some hypotension, passive hypotension, but that's argumentative, debatable, and you're going to get contradicted information if you go look that up, and you should. You kind of just want to try to maintain a normal blood pressure if you can, but it's something to consider because that sucker pumps in a lot of volume fast. Anybody know the number? I don't. I just know it's stupid fast. I mean, it's like a unit of blood in 5 minutes or, yeah, right? It takes one human needs to be running that machine, right? And before you've dumped in 8 liters into a patient, you're like, oop, I think I overdid it. And then, this person could be bleeding anywhere, right? And it may not be showing you yet. You can't see it, right? There's blood on the floor. Add 4 more. That's another term they've talked about. If you can see the blood and it's filled up a container somewhere and then it's come out. If you think about it, right? So it's either filled the gut and then rode the esophagus up and then out, or it's here and then out. This is a short distance. So this really goes, or they're digesting it and it's coming out. Bright red blood per rectum is a thing. Is it bright red? Is it coming from there? Normally it's black and it's from above. It's partially digested because that's the iron, that's the heme. Your stomach's like, I think I'll chew up red blood cells for nutrition today. And what's left over is black tar, right? So you got to look for what color is it and how much and what direction is it coming out. Next. Why are you so sleepy, my man? This must be funny. Ammonia level, arterial or venous. It used to tell always arterial was the gold standard. And it is, but it's not that big a deal. And kind of depends on the patient. If I get an ABG complete, if I have the right person there, they could probably dry stick and get it all in one shot, but that's really not realistic hardly anymore either. I get ABG complete, I'll get H&H and all that other good stuff. So a lot of times I'll do that, and we'll still send a rainbow if you can get it. And with that rainbow, you need an ammonia level. Is that lavender? Is it green? Yeah, lavender. Okay. Sleepy equal plus ammonia level high is hepatic encephalopathy. Treat with lactulose. We talked about that. We don't give it fast enough, and we don't give enough of it. And it's pretty higher priority. Head CT to rule out other causes of encephalopathy. If you might snag one of those old, if they have bands from before, then you might knock one off. We've even requested an NG tube or an OG tube to be placed during endoscopy in OR, or even with a gastric sew over, and they still didn't put it in because they were like, the GI doc said no. Sometimes you'll have one and they'll pull it because they need more room to put their camera, put the snake down there and look around. So they'll pull your OG and G and not put it back because it's too risky. So then you're just kind of screwed. So you're stuck with lactulose enemas, which is a lot. 200 grams and 700 mils of volume. They're going to butt chug that. You need a retention. It's got to stay in there. It's getting people to hold their feet up while they do it. Lactulose, yeah, so it's important. Next. Why you look pregnant, sir? I wasn't going to say anything, but you got big feet too. So ascites, portal hypertension, albumin is stupid low. Drain me, please. LVP is large volume paracentesis, and give albumin for low BP, and do it when paracentesis is happening because it's going to drop blood pressure after you take off a lot of fluid. Having a decent amount of respect for paracentesis, volume removal, and low blood pressure is important. And it's a lot more albumin than you think. It's not just like 2 small ones or 4 small ones. It might be 8. There's some numbers, and they're buried in my book. Page 2. Albumin infusions. Renal hypoperfusion. So if you don't have enough blood flow to the kidneys, is an important part in the pathogenesis of hepatorenal syndrome. If you want to avoid that, have evaluated the role of albumin. Studies indicate infusions of albumin can reduce the incidence of hepatorenal syndrome and spontaneous bacterial peritonitis. So if you got SPP, you're at high risk for renal syndrome. You got 1 organ problem, you don't need 2. And this is how you end up in multi-system organ failure. You got to kind of keep the other organs preserved too. High risk patients, those with BUN greater than 30, creatinine greater than 1, and a bilirubin greater than 4 are the lab values that are listed here. Recommended albumin infusion regimen is as follows. Day 1, 1.5 grams per kilogram of body weight, infused within 6 hours of the diagnosis of SBP. So we need to get that. We need to get the volume and the osmotic pull in the right direction. Day 3 is 1 gram per kilogram of body weight. Unclear at the time if the benefit of albumin is volume effect or it's related to some other effect. Example, albumin has an antioxidant activity and can also bind cytokinins, which is interesting. So it might have some effect on inflammatory response too. But what my experience, if I keep giving crystalloid over the years, I've seen people give too much crystalloid, that's LR, NS, and it seems to go where it gets pulled to. So I've seen, if you use crystalloid in the ER and they're going to fill up, and they got it in the ambulance, they got it in the ER, and now they're coming to you, and the belly's going to, if I keep using it, we're going to get in trouble. So if I'm low blood pressure, I'm going to albumin. This guy talks about albumin and why it's important and you need to use it. So I use that for the blood pressure a lot and stay away from the crystalloid. And then when they go get tapped, or if they tell me, hey, I got 11, I've seen it where they say, hey, I got tapped yesterday and I was doing okay at home. They took off 11 liters and the guy got some albumin and went home. Yeah, I'm like, outpatient? And then comes into ER with low blood pressure and encephalopathic. So I start with albumin again. Like I said, crystalloid he seems to make more ascites. It's going the wrong direction. When they go to get tapped the next day, I try to make sure that I got a decent blood pressure and I reduced the amount of Levophed requirements and tried to make sure I got the albumin up because they're already low. I'm trying to get them normal. Then they're going to go get tapped, and then everything's going to shift again. And then it may go right back to the gut. We've seen these guys need to get tapped again 3 to 5 days later in the same week. So they might have to keep going back. They get 5 off one day, another 5 off the next day. So crystalloid's not exactly your friend. Keep slamming it in. I try to replace with what's lost. If they need albumin, give albumin. If they need blood, give blood. And then if they're really needing blood resuscitation, the hemorrhagic shock, balanced resuscitation is, if you've heard that term, you want to give balanced blood products, not just blood only. If you only give blood, the blood gets higher, but everything else goes down because you're going to need FFP, you're going to need platelets, you're going to need cryo. So intra-abdominal bladder pressure. I had something on that too. Where'd that go? That's this one. You guys got this one? I found this in my Lisa Berry Wayland locker from like 20 years ago the other day. This is from the World Society of Abdominal Compartment Syndrome. But that's a fun group. Do you think there's like more than 2 people in that and they called it a society? It's like somebody named Helen and her buddy Judy. And they're like, let's make it a society. Intra-abdominal hypertension assessment algorithm. There's some imaging that goes with this if I have it, but there's grading and what's bad. We always just get a number and we really don't know. This is what that number's based off of. They used to tell us kind of a good rule was if it's 21 or higher, it's probably a surgical consideration. You might need to open something up. That's a big step. So if you can get an NG or OG tube to decompress the gut, that's a good start. But you got to not knock off any bands on the varices. So it might be a no-no. Might need permission from a GI doc if you can do that or not. And then ascites puts pressure on the organs. Main problem is if the intra-abdominal pressure is a trapped compartment and it's a closed container, and if there's fluid and volume in there, it's putting pressure on organs. You're compressing organs. They're under pressure and they're going to get mad. And there's a lot of organs in there. And then if they're getting mad, by being mad, I mean hypoperfused, so you're not getting oxygen and blood flow to the tissue, to the organ itself, or to the bowel. So that, in definition, is shock. You're not getting tissue perfusion to the organ. So it goes into shock. Shocked organs start to give you a little bit of a warning by throwing some enzymes, right? They'll start throwing off some lab values. They're telling you they're being beat up. And then after that, if they start to fail, now you're in multi-system organ failure and chances of survival is slim. And you already showed up with one organ failure. So this one's kind of useful. You can keep this, use it. And this is why we do the bladder pressure stuff. Why are you drowning on your own blood? It's making the new PCA freak out. So, thank you. They do too. And then they don't yell as much as usually your experienced nurses yell down the hall. What? I never forget my first esophageal varices exsanguination, and it was Pete's patient. Anybody here that night? Anybody? She's probably it was. I was sitting on the other side of the counter next to the monitors, and I heard splash. That's like, oh shit. Then I heard Pete go, what? And he's right there. I was like, oh shit. So I stand up and look over the counter, and there's a big puddle of blood, bright red. And this guy's going, like, oh Christ. Oh, that's not good. And then they usually do that, and then they retch a couple, and then they roll back. And it's like that. So step one, hey, you're getting an admit from the ER. It's just go ahead and get suction set up, okay? Suction. Every room in the ICU, honestly, every admit should probably have suction. These guys are really useful to have suction, have a yonker. Yep, and that hard plastic one, not the just toothette one. Hard plastic, that hard yonker. And in this situation, taping the hole is good. And then no one has to have that extra thumb busy. You got to open the airways so they can breathe. Otherwise, they're going to die. And for one, you're going to die 2 reasons. One is they're exsanguinating. They're hemorrhagic shock. Yeah. Blood loss. It's one of the H's and T's. The other one is hypoxia. They're not breathing through all that red paint. So, and they're encephalopathic, so their GCS just dropped. You got about 3 reasons to tube this guy. And you got about 3 seconds, so whatever. So this guy's a bloody mess, and I run in there, and I got the yonker, and as long as you keep suctioning, you can keep his mouth clear, but you're stuck there. You can never do anything else. So you're going to have to come up with a plan. Why are you drowning on your own blood? So the varices have now ruptured, and it's an emergency. You're not leaving that room. If it's a lot and your patient has gone like unresponsive, just pull the code because you're going to need all hands on deck. You're going to need at least 2 RTs in that room, plus you, plus the provider, somebody that can intubate. And then you're going to need somebody just on vitals and hemorrhagic, right? And if it's a code, it's a code, and we all know what to do there. As far as airway, there's some, Taylor and I both went to an airway course, and then it would have been useful to have gone to this course before having a few trash airways, but you learn. That yonker, taping the hole and having it ready, you can intubate, or I get in there and you just stick it down into the esophagus. Stick it. Not aiming for anything. Just stick it in there and let it keep suctioning. And then hold it there, and then go in with the camera and lift. If the camera gets wet, the small handheld one I got, if it gets wet, it whites out. It's good, but it's not great in wet. So in the old-fashioned glide scope on wheels, I found I've had better luck. It handles wet better. So if it's going to be a yucky, wet airway, then I like to use that one. And stick the yonker down there, and it's got to stay. If I have a friend on the left that can keep that yonker right where I stuck it, that's really helpful, because as soon as that comes out, it comes right back up. And you're just hoping you can get it out of there, keep it out of there fast enough to be able to get a view of some cords and stick the tube in it. And sometimes if it's coming out too fast, aim for the bubbles, and you're hoping for the best. Yeah. And that's it. Because you can't even bag this. You can't. It doesn't work. And there's no end in sight. So there's a lot of advanced. Yeah. There's no end in sight. You just got to kind of get the tube in faster than the blood's coming out, and then you can oxygenate them, and then that's one more friend on your side. Oxygen's getting into the lungs, and with a definitive airway, the cuff inflated below the cords, maybe you're keeping blood out of the lungs. So that, you already have this problem, and then if you have lungs full of blood, you have that problem, and that's not very survivable either. So being prepared to intubate at any second. So a lot of times, if it's bad enough, I just set all this crap outside the room. Just have it all ready so that it ain't a drop of a hat. You can run in and try to tube your patient. Tube of red paint. So I got that guy tubed. I got lucky, and I chased the bubbles, and I got in, and I kept suctioning, and I didn't have a friend, and I should have, and I didn't have the tape on the thing, and I'm just holding and suctioning, and then I take it out and grab my tube, and here it comes. And then I put the tube down, and I go back down, and I suction, and then I take the tube out, and I grab the tube, and then here it comes. And then after a while, you realize that's not working. So that's why I suggest all the other changes, the extra hands. So I suction and see the blood come up, and I'm trying to memorize where it was and shoot the same spot I had in my head that I saw a second ago and chase the bubbles, and I got super lucky, and he died anyway. So that was a good lesson that you can tube and have a great intubation, but I still have no blood to circulate. You still die of hemorrhagic shock with a good airway. So that's why these are so scary and exciting, and you kind of got to try to predict everything. But once those things blow, I think the mistake I had that night was not knowing for sure if it was liver failure, not knowing exactly how to treat acute on chronic liver failure, because you don't always have any information. Maybe they came from an outside hospital. You don't know, but you have a hunch that maybe there's something liverish going on. And his lactic acid, liver has jobs to do. One of them is to clear the lactic acid, and if it's a dysfunctional liver, it can't do that. This guy's liver, every time I drew labs, they kept going up, 80, 100, 120. The lactic acid kept rising. It turns out you can't hydrate that away with crystalloid. And if you do, they worsens portal hypertension, which worsens the variceals, and then they blow. And then, so when I was reviewing all the things, like what should I do different, I went back to this and started teaching myself more, because I don't want it to happen again, and learn from that and try. So every situation, get in a habit of thinking what you can do differently on the next patient. Blood on the floor, 1 unit, 2 unit, 3 unit, 4. My other title was going to be hemorrhaging. There's only 16 slides. We're 9, so we're getting there. I'll go faster. Are you bleeding out? Is your albumin low, blood pressure in the dirt, and coag's got you down? Just call 6215 and ask for Trudy. It's mostly like a radio ad. Hemorrhagic shock, bleeding out. Is your albumin low, blood pressure in the dirt, and coag's got you down? Just call 6215. That's blood bank. Ask for Trudy. She's happy to help you. No, she's not. This is Trudy. Blood bank is open 24 hours a day. Trudy, if you're on here, I'm sorry. Stop parking in our parking lot. She does. She backs in and parks in the PAAP provider parking lot all the time. Blood bank's open 24 hours a day for your extenuating needs. This ad is paid for by your local pathologist. Recommended steroids and Levophed. Steroids help with your adrenal insufficiency. Levophed is the recommended pressor of choice in these patients because they put it on this paper towards the top. After that, you need balance resuscitation, which is why I say crystalloids not exactly your friend all the time. You got to start with something. It's cheap and nearby. So start with it and then get to the other stuff. FFP, platelets, low enough to qualify. Less than 50 and hemorrhaging is a thing to click when you're choosing platelets on the blood transfusion order set. Click it. And because that's what got me platelets last week. Less than 50. They were going to tell me no, and they had to call the pathologist. And there's only so many platelets in-house. Anybody know the number? How many bags of platelets they keep in-house? Nope. You're closer to maybe one. Sometimes two. Two is their part for the whole hospital. There's 40,000 people in this community. This hospital keeps 2 units. You get a trauma, it's going there. You have an open tomorrow, it's going to get saved for that one. But you have to tell them my patient's dying right now. My patient's exsanguinating right now. It's a different organ. It's GI. It's not cardiac today. And I need it now. So then they say, but I only have one. So if I give you that one, I said, the Red Cross, they call Red Cross. They do some magic driving of truckers and state police, and they get more products here. It's what they do. They have that system, and the pathologist is going to get a phone call in the middle of the night, and they're going to have to do that. 19, other platelets of 19 seems to be the cutoff. It's where I can get platelets, unless they're hemorrhaging. Then it's less than 50 and hemorrhaging. So anyway, don't take no from someone who can't give you a no or a yes. Right? Stay on the phone. Don't skip on the cryo. And cryo is kind of a big part. So if you get platelets and cryo and FFP and blood. And then if you could vote on a title, that would be good. Did you like hemorrhaging or the first one?
Based on the floor was informational. It's not helpful.
It's got a rhythm to it. I don't know. I guess it depends on the mood you're in at the time. Lights out. Get it? Lights. Anyway. I'm starting to run out of ideas by this point. My Lotus drink is wearing off. Things I've seen low. Sugar drops. Calcium's low. Sodium's low. And sometimes potassium's high. Sometimes everything's low. Magnesium can be low. Your alcoholics, sometimes it's what they used to call beer potomania. Everything's low. They drink beer. They don't eat vegetables and fruits, and they don't have they drink beer every day. So stuff I've seen low. So the sugar, glycolysis, glycogenesis, liver's got a job to do. Liver isn't doing its jobs. It's having a bad day. Sugars, I see them run 80s and 70s and 80s and 70s. Doesn't mean they're diabetic, but you kind of got to watch it because they don't have a lot of reserve, right? And it's not able to do its job to go into the pantry, take food off the shelf, or put food back. So sometimes you have to give them a little bit of sugar. And if they're NPO, you got to find another way. So it's probably going to be IV. Is it D5NS, D5LR, D5 in water? Got to watch the free water because sodium's also low. And if they're acidotic and I do a bicarb drip, that's a dextrose, but it's in water with 3 amps of bicarb. So there's more water. So I have a sodium problem. Acetylcysteine, right? Is that anybody ever given that? It's like 1 or 2 liters up front, right?
Yes.
And a
Like
couple.
the big to the smaller, so 3 different bags.
It's got it. If you could find a way to do it just as the drug alone, but it's in a big giant liter of D5 water. So it's more free water, and it's about 4 liters of it. So it's acetylcysteine. You've given it, and it's got its place for like Tylenol reduction. But some studies say it's got some benefit and low risk for in liver failure. But the problem is it's a lot of free water. So I've seen it initiated, and then I've had to stop it because sodium's 118. And it started at 124, and it's 122, and 118, and then I don't want to see what's after 118, so we stop. What happens when the sodium gets too low? What are they going to do? Seize, right? If you thought you had an airway problem now, wait till they're seizing. Calcium runs low, and then albumin's low, and then there's the corrected calcium for hypoalbuminemia. So anyway, a lot of these, and then if they are acidotic and you're on a bicarb drip, bicarb tends to push the calcium lower too. So you got to I'm going to end up giving a lot of calcium to these guys too. And the liver has a job to do with calcium, and calcium has a job to do with the coagulopathy path, right? The intrinsic pathway for, I don't know. Don't ask me. It's ridiculous, right? Everybody see the table in their head of how thrombin, prothrombin, this complex, that complex, and where calcium does. And I don't know how many years I've had to look at it, and it doesn't make any sense. I don't need to know it. I just know that if it breaks down, they bleed to death, and there's some things you need to do about it and how you can manipulate it, but you don't have to understand the whole thing. Replace calcium, replace albumin, make sure the sugar stays up. So we're going to do glucometers around there. We're going to I can get an ABG complete. I can see ionized calcium on that. If our arterial sticks is a bad idea because they're coagulopathic, then we're doing venous. We'll draw labs. You just got to wait longer. The worse your labs are and closer they are to death, lab values, the more you're going to get phone calls from lab, right? And a lot of times they think these aren't compatible with life. So if lab values that are not compatible with life usually don't pass their chemistry analysis stuff. So they're going to ask you to redraw. That's something that takes a few years to figure out. So if your patient's that bad, sometimes you got to tell them they're that bad and you should turn them out because they're going to die any second. And they need something to go on. I speak from experience on that with a STEMI that was not a STEMI. It was actually throwing clots, and the lady was actually in ER. We called down her. I went down there for a STEMI call, right? If you've been on a charge nurse and you got a pager and you go down to ED for a STEMI call that turned into a liver failure, turned into bleeding out and throwing clots, DIC, and cardiac arrest and death. It's not an MI. Weird. How fast and how interesting that changed and how the symptoms overlapped each other. She was tossing clots and had probably a coronary occlusion, but also then she looked like a stroke. Was it the morphine for the chest pain, or did she just stroke on me? What's her sugar? Everything was going wrong so fast. And then lab calls, and I remember that because lab's like, "Hey, can we need a redraw?" I'm like, "This one's gonna die any second." And what's off? She's like, "Well, this didn't pass. This didn't pass. All the values." And then Tim, I said, "If you can give me any number, I'll tell you what's going on." And they were in DIC, full blown. Came into ER and presented in DIC. Blows your mind. So if you've seen DIC, you're bleeding to death and throwing clots at the same time. It's exactly what she was doing. Almost never is there an ER presentation of DIC. So this woman had been decompensating at home too long. Yeah, so acute on chronic. It's crazy. Sodium's low. This is osmotic issue, right? This is an osmotic issue. Free water doesn't stay where it needs to. All your fluids going to your gut. Careful with making this worse. I'll just point that out. You got poisons in your belly. Yo. So this is SBP. I thought it'd be fun. And just in case you have trouble sounding it out. Acute and chronic liver failure with ascites. So this isn't always going to be, they pointed out this is acute on chronic. So this is a chronic liver patient that has an acute deterioration, right? And it's not going to be your acute liver failure with no history of liver disease. So 10 to 27% of these have evidence of infection. That's kind of it. So if you have ascites and acute on chronic liver failure, you have evidence of infection 10 to 27%. Without a primary site of infection. So fever, 50% present with a fever, abdominal pain, and rebound tenderness. I lost them on poison, didn't I? Translocation of bacteria across the bowel wall into the peritoneal fluid. Diagnostic paracentesis. Tap it and get a culture and send it, right? There's an order set for that. My biggest fear on those is sometimes you get a doc or they went somewhere, they got tapped, they set all the fluids off and no one releases the order or doesn't activate all those list of orders. So then they kind of hang out there. So then so anyway, make sure you check your orders in the lab, make sure these kinds of things are sent. If you can find out what it is, we can throw the right antibiotic. Common types of infection then is the gram-negative bacilli E. coli. 75% of these are that. The other 25% are gram-positive streptococcal. So picking antibiotics that cover both. Treat with antibiotics. Ceftriaxone is what's normally given, 1 to 2 grams. It's going to be weight-based and renal function-based, but 2 grams is where they like to start. And that's the prophylaxis. If you don't get it, because maybe it's not safe to tap that belly and put a needle in there yet. Maybe they're in DIC. So you're just going to have to start antibiotics because they're not going to survive if you don't. Thiamine, don't hesitate on the folate. It rhymes. Alcohol gets this stuff, right? So you have your alcoholics. When we have alcohol withdrawal patients, we're giving thiamine and folate. Why do we give thiamine? Wernicke's encephalopathy. You need to give the thiamine before you give glucose. Otherwise, you can kill the brain off. Wernicke's encephalopathy. You already have hepatic encephalopathy. Why add this one too? They don't want to double down on your encephalopathy. So give thiamine. I don't know if there's a random. I've seen 200 BID. I've seen 200 daily. I've seen 100 BID. I've seen 100 daily. I don't know if there's a number. I go up to 200. I don't know. Why not? Folic acid needs replaced as well. And then anemia workup, if it's if they're not hemorrhagic, anemia workup's nice. Maybe they've got other reasons to be anemic in addition to blood loss, which could be macrocytic or microcytic or normocytic. That's the MCV on your CBC. B12 and folic acid deficiency would show that. So, and that in your alcohol anemia, that's usually where it's B12 and folic acid. So that's why the folic acid. The idea is just to try to reduce anything that's going to make bleeding to death more possibility. End up giving IV most of the time. GI doc Bosdek years ago told me the first 72 hours in alcohol withdrawal type setting, thiamine needs to give IV or IM. The gut can't absorb it for the first 72 hours. That's off the alcohol withdrawal order set. It's why you see it ordered that way, and it should be ordered that way. If not, maybe ask a friend to change it. After 72 hours, if they can take PO, then we can switch back to PO. Multivitamins, another one to add on, but you've seen all these things in a banana bag, right? Vitamin, folic, and multivitamin in a banana bag. That's good for just your good old-fashioned withdrawal patient, but that's a lot of volume again. And if you're gonna run a banana bag at like 80 an hour or 60 an hour, it's gonna take months to get that in. If you're running it at 100 an hour, it's gonna take 10 hours to get it in. So you're gonna give them a liter of fluid over 10 hours daily. You know, if they're going to be here in your ICU for a week, that's 7 liters up just off that volume alone. So we watch INOs pretty close, right? So that's a lot of extra volume. And it's usually in what, LR or NS or something. So there's your crystalloid again. So I think over the years, we've shied away from banana bags. That's why. Anybody ever given a banana bag?
I've seen them come back recently.
Yeah.
Yeah, I've seen them.
They call it that because it's yellow. When you put the multivitamin in, it's bright yellow. Sorry, we do not accept tips. Thank you. TIPS is transjugular intrahepatic portosystemic shunt. It's a big word. I was always curious what it meant. I just knew we didn't do it here. And it's the end of the line. It's like, ooh, that one's bad. He needs to transfer to Barnes. He needs to get a TIPS procedure. Like, that sounds good. Barnes is closed. Shit. And we call everybody else, right? So I went and looked it up. I learned a little bit about this because I never had the time to sit down and just look it up. So this is what it is. Used in recurrent variceal bleeding after medical and endoscopic intervention. So you've already tried to stop all the bleeding. This is all about back pressure, portal hypertension. So there's pressure buildup in the portal vein causing back pressure and up all these little routes, and it ends up along the esophageal wall where there's blood flow and an arterial, and then it gets back pressure and then swells and ruptures on the soft spots, and then you bleed to death. It puts a stent of flow in there. It reduces variceal bleeding. This is a YouTube video. It's about 2 to 3 minutes long if you want to watch it. But you can also just Google TIPS procedure on YouTube and watch a quick 2-minute video for yourself if you like. Because I'm on. It says IR. Interventional radiology, which we have, but maybe I'm not sure why we don't do it here. I don't know why. And there probably is. There's a good reason. I just don't know what it is. Yeah. Uh-oh. Oh, it died. It is. Ah, there you go. I'm in. Okay. Now, how do we help the yellow man, you might ask? So, in a nutshell, this is another antibiotic, but ceftriaxone is what we're going with. 2 grams, Q8. Mortality rate on SBP is 30 to 40%. And that's with the right drug. 30% of liver failure patients with SBP get hepatorenal syndrome. And mortality risk with that then is 50%. Flip of a coin. So, hey, you think your patient's going to die? Could be. Maybe. 50-50. That's really crazy. What else can we do for great Uncle Jaundice? So in a nutshell, give a crap ton of albumin, manage ascites. It might have to get tapped. Might have to get tapped every few days. Low salt diet, spironolactone starts at 100, goes up to 400. It's potassium sparing. Diuretic. Lasix start at 40, goes up to 160. All this comes off of these. And it's not potassium sparing because that's also important to have some balance. You don't want to keep sparing your K, and next thing you know, it's 6.8. Large volume paracentesis is a big deal. If you get this information resource said if it's more than 5 liters off, you're going to need albumin for sure. You might need some anyway to get back to baseline. And after the paracentesis of 5 liters or more, you're going to need more. Hey, dog, want to switch me livers? About 10% of patients with cirrhosis and ascites are resistant to diuretic therapy. So 10% of this group, diuresis isn't going to work. So if you can't get volume off and it keeps coming back, it's not good. And you need to go for a liver transplant. You just give up. That liver's junk. You cannot make it walk anymore. Yeah, they're going to have to. Hopefully your patient get a new liver. And that's it, because that's liver failure. If it's failed to the point of no resuscitation, you're going to have to replace it. Thanks for laughing at my jokes.
Good question. What is DIC?
Disseminated intravascular coagulopathy. And you're bleeding to death and throwing clots at the same time. It's a drastic unhinging of the clotting process. Yep.
So many clots run out of your clotting vectors, so then you start bleeding to death.
So you can toss clot, so you can have ischemic areas where clots go, as well as you're bleeding to death at the same time. So things that you tend to see is gradual signs like, hey, this guy bruises easy. She tells me she bruises easy. The patient down in room 2 was fibrinogen was under 100 when we got to see what her numbers are. Hemoglobin was 4 something. She says she's not an alcoholic. She doesn't use any ibuprofen. She doesn't use Tylenol. But she does know sometimes she blows her nose every morning and it's always a little bloody. She bruises easy. When she scratches, she always bleeds easy. If she falls, she bleeds easy. Sometimes she wakes up in the morning with her lips stuck together a little bit with dry blood. It happens quite often. And she always has to kind of work that off in the morning. Sometimes they say my gums are always bleeding. So there's something going on, right? And we start checking labs. This old lady's been sitting in smoldering type DIC with liver failure that was like room 2 last week. Yeah. I was like, what the hell? So, you check Tylenol level, you check INR. INR was up, hemoglobin's low, platelets are 35, hemoglobin was 4 something, right? Fibrinogen was under 100 or 100 or something. 200 would have been great. 100's not great. So I'm like, oh my gosh. So she's at risk, and hematuria is another thing. Do you notice any blood in your stool? Have you been? Sometimes I cough up a little bit of blood, or sometimes I throw up. I've been vomiting in here a little bit, and I get a little bit of blood. So it's usually multiple areas. It doesn't have to be liver failure, okay? It can be septic shock. It can be cardiac arrest. You just straight up, some old dude died, got a buttload of CPR for extended length of time in the field and in the ER, and then they come up. Our young man who had total of 60 minutes accumulated, 20 minutes out of hospital, 40 minutes ED, total 60 of cardiac arrest. His fibrinogen was 100, 130 or 50. I don't remember. He looked like, right? DIC down there, like room 14 or 13 as well. This guy doesn't have a liver problem. He doesn't. But cardiac arrest, you don't have blood flow to any of your organs. So multi-system organ failure is going to be a thing. Huh? Yeah. Did he have some drugs and alcohol? Yeah. So then that predisposes him even worse. So DIC is going to show up in that guy perhaps too. Septic shock shows up there too. It's your chance of survival in DICs once you hit that is pretty low. But yeah, they're usually what I end up seeing is you guys are like, hey, there's a little bit of blood in his Foley. I haven't seen that before. Hey, there's a little bit of blood in the stool. Or you just get a gastric cold or something, and there's a little bit of blood in the NG tube. And then like, hey, all my IVs are oozing a little bit. Hey, can I put some pressure or get some clot stuff on this central line you put in 2 days ago? Things are starting to, and you're like, oh, hang on. Let's get some coags. Let's check fibrinogen. Like, D-dimer's elevated. It's like, this dude's in DIC. Dang it. Cryo has got me out of that. Hemorrhagic shock trauma that have gotten mass transfusion, I go ahead and assume DIC's coming any second, probably before morning, because they really are. The clotting factors are in the crap after. We gave him 32 units of blood. Okay. Then you check in that, right? Or more. We've had it. That's the report I've always get. 32 units. You got 80. You got 40 units, 50 units, 20 units. Did you give any FFP? Yeah, we gave some. Did you give platelets? Just one. Okay. Anybody check fibrinogen?
What's that?
Huh? Then check fibrinogen. They got none. So cryo. You want to give cryoprecipitate is the fibrin. And you got no fibrinogen. So you get fibrin. So otherwise, you bled to death. You refilled the tank, but there's still a hole in the tank if you don't glue it shut with the fibrinogen. So,
Thank you.
yeah, sorry, a little overkill, but any questions, thoughts? I hope it's useful to you. I'm still learning this. There's obviously there's going to be more to learn every time I have a patient. Either things I already know are re-supported, or additional knowledge comes out of it, and then we learn something new. And with more of a GI presence now than we've had in a few years, I'm able to learn faster because I can talk to that guy or I can read his notes, and I'm not out here winging it. So it's been very helpful. So we'll see what I know at the end of the year. It might be. Goodbye, people at home. Have an amazing day.